Thank you all for being online with us today. I know this is a difficult time for all of us, and hopefully this will give us a chance to look at some things that are happening and try and keep you up to date on what's going on with even COVID-19, especially with some of the things that are investigational right now that are moving at a tremendous pace. So as far as my disclosures, I don't have any disclosures I need to make as far as my, there we go. I haven't spoken for industry in about 7 to 10 years. I don't serve on any advisory boards, so I don't think I have anything that I need to disclose to you about having any biases with what I talk about today. This virus, while this one, COVID-19, is new, the coronavirus is an RNA virus that's been with us for a long time. It's caused maybe 20 to 30% of the common cold, a different strain of it. It was also associated with SARS and MERS. So MERS, we've had this virus for a long time, but this is a change, and we believe it came out of Wuhan, China in December, and people now say probably back in November. We didn't know about it, but typically the symptoms are somewhat like influenza: fever, tiredness, dry cough, and when it's severe, which is luckily not most patients, but especially those of us who are chronologically gifted, it may also affect our ability to breathe, and that's where a lot of the problems come in. May also have direct toxicity, not only in the lung tissue, but also in the heart. And it looks like there are underlying medical problems that increase our risk of bad outcomes. Chronologically gifted as we get older, especially those 60 and older, those who have high blood pressure, those who have a history of heart problems or diabetes, those with lung disease, malignancy, all those are folks that tend to do worse with this disease. And if you have any difficulty breathing, you need to seek medical attention. And to do that today, it's evidently for everybody, it's online. So you either call a number or you go online and seek your medical attention. Don't go to the ER, don't go to your physician's offices. Most of them are not accepting patients that way unless it's a true emergency. The two new symptoms that have come out recently in New England Journal were anosmia, where we have difficulty in detecting smell, and also reduced taste. They may also be associated with COVID-19. So those are a couple of new symptoms that have been added to the list. And what can we do to reduce our risk? And this is social distancing. These are all the things we've been asked to do by the President's Commission and also the CDC, and almost every health agency in the world is doing the same thing now. So wash your hands, ideally with soap and water. If you're using alcohol-based hand rub, if it's ethanol or isopropyl, it's 60 or 70%, depending on which one it is. It's at least 20 seconds of washing with the soap and water, and go through, sing to yourself happy birthday twice, and you're about the 20 seconds. Maintain that social distancing of at least 6 feet between yourself and anyone else, especially if they're coughing or sneezing. If you cough or sneeze, do it into your elbow or into a tissue and immediately throw the tissue away. Avoid shaking hands. So we no longer pass the peace by shaking hands at church. We bow at each other, or we give them the peace sign. Sometimes we'll do an elbow bump or a foot bump, but ideally no direct touching, and maintain that 6 feet of space. Avoid touching your eyes, your nose, and your mouth. That's where this virus gets entry into the body, into the upper airways, and it actually can get in through the eyes, and why we have the face shields with our protective equipment. Make sure that you and the people around you follow good respiratory hygiene. So if you've got a cold, you don't go anywhere. You stay isolated, even from other members of your family in the house. Have a room that you can stay isolated in, and you don't need to be exposing anybody else in the home. Again, make sure you cover your cough and your sneezing and throw the tissue away immediately. If you're not certain how long it survives on surfaces, we do have some data I'll show you that it can be up to several days, hours to days. We'll come back to that. Stay at home, which pretty much everybody except a couple of states are doing right now, stay-at-home order, and that is working. As I'll show you, it's working. Keep up to date on the latest hotspots, and right now, New York City is still ground zero, but New Orleans, Detroit, there are lots of cities around the United States right now that have a huge number of cases, and we'll look more about that a little bit later. But again, if you have any of these risk factors, use social distancing. Don't be involved getting close to other people. Even going to the grocery store, even though they have times now that most of the stores are open for an hour in the morning for let people 60 or 65 and older come in to shop with nobody else, limit the number of people you're around. Have somebody go to the grocery store for you if you have risk factors. If you're older, you have hypertension, heart disease, diabetes, cancer, lung disease. Those are the folks that do not need to be around anybody else, especially at this time with the contagiousness of this virus. Here is the new updated slide from the president's guidelines. It used to be 15 days to slow the spread. It's been updated to 30 days, so it's essentially this month of April right now. And these are from the CDC and from the White House. So didn't really change anything except they added another 30 days when the 15 days ran out. So it's really going to be 45 days total if we look at what they've done. Here's, again, the same thing we've already talked about. So this did not change from the 15 to the 30. It's the same slide. Here is the data that was published in New England Journal last month that looks at how long this virus lives on different surfaces. And if we look at aerosols, it is the shortest. Those are hours, 0 to 3 hours at the bottom. And what you see there, the orange bar is the SARS coronavirus type 2 that we're talking about that causes COVID-19. The blue was the original SARS virus from several years ago. If you look at it on copper, it's very short on copper. We've got some data that even bacteria tend to live on copper very short compared to other surfaces. So copper is one of the things that appears to have some antimicrobial, antiviral properties. Cardboard, you can see the coronavirus lives on cardboard a little bit longer. So that one is actually, if you're looking at in time, it's significantly longer. Same thing on stainless steel, it lives even longer, and on plastic it lives even longer. So ideally up to 2 to 3 days, depending on what the surface is that it's on, that you can still have viral particles. But this virus is really not alive. It requires human cells or animal cells to replicate and survive. Without it, it dies. And that's why we have a time limit on how long it survives on surfaces. So what's the incubation period for the coronavirus? Most of the estimates are right around 5 days is the most common number, but it's been as short as 1 to 2 days, and we now have data out to 21 to 24 days. But the average is somewhere around 5 to 5.5 days is the usual incubation period. Here's the data as of yesterday as far as what's happening worldwide on the Center for Systems Science and Engineering at Johns Hopkins University, the map that you see. As of yesterday at 2:55 in the afternoon, 1,400,000+ cases in the world. United States was pushing 400,000 cases as of yesterday afternoon. Spain was number 2, Italy 3, France, Germany, mainland China is going down. And again, we don't know if any of these numbers are correct because the testing is not there. We do not have sufficient testing. So these numbers are likely to be significantly lower than the actual numbers. United Kingdom has had a significant increase. And here's the death count as of yesterday. Over 80,000 deaths worldwide, over 12,000 in the United States. And again, these are probably underestimated because if you died at home and you'd not been diagnosed with COVID-19, you're not including these numbers. And some of these folks have died without going into the hospital, and they're not included in these counts either. So this is continues to change every hour, and it's still going up, sorry to say. It hasn't leveled off yet. Some countries have, but not here. Here is the no evidence to support transmission with food. So if you eat food that somebody else has prepared, we've got lots of takeout right now all over the country to keep some restaurants open and surviving. That does not appear to be a significant risk from that. And the food itself, when you ingest it, that's not the way that this virus gets entry into the body. So right now, the FDA and the CDC basically say, keep your hands clean and wash with soap and water before you eat, and don't touch your face. Those kind of things will minimize your risk. We also don't have to worry about food that we buy, or even if it's shipped to us now, like Omaha steaks or whatever, you have it shipped to your home. You might want to leave the box out for a day, since but in the case it's frozen, you've got to take it out. When you do, there's no potential that you're getting coronavirus from the person who packed that food, even if they were to be infected on the other end, which hopefully they're not. Here's some of the data that we got out of China early on that is very, very concerning. Some of it's good. When you look at the mortality by rate of age, you can see that children have a high mortality with influenza virus, but not with the coronavirus. COVID-19, kids, very few, if any of these kids have died. In China, they had no reported deaths less than 10 years of age in China due to the coronavirus. And that's been happening worldwide. So it really doesn't start to go up until you get to around 60, then you start to get your peak. And as you go up 60 to 70 to 80 and above, it goes up dramatically. So that's the mortality rate based on the China data originally. And on the right-hand side is pre-existing conditions along the bottom. Heart disease has the highest mortality rate. Diabetes was close second. Then you had chronic respiratory diseases, so our patients with asthma, COPD, high blood pressure, which generally we don't think of as a condition that usually increases our risk of other than coronary disease. We don't think of that causing bad outcomes when it comes to pneumonia or to infectious diseases. And then we have cancer, and then we have where they have none of these risk factors, it's very low. So these are the major risk factors that we've seen based on the data, and we're seeing this in the United States today as well. The other risk factor that I'd add based on new data is African Americans. We've seen a disproportionately higher rate of mortality in African Americans in the United States than we've seen in other populations recently. So that's something that's coming to the forefront right now. Here's some data that was in Journal of the American Medical Association, JAMA, recently comparing China to Italy. And this is looking at case fatality rate by age group. And if you look again, 0 to 9, there were none. 10 to 19, very, very few. 20 to 29, very few. You start to pick up again when you get into that 50 and especially the 60-year age group. And in China and Italy was very similar in the 60s. It was also a little higher in Italy in the 70s. And when you get into the 80s and above, it was much higher in Italy than it was in China. And especially if you got in Italy 90 and above, those people were over almost 23% mortality rate. And if they have underlying conditions, it's 50+%. So high mortality, and that's also true with influenza, but unlike influenza, we don't see a high mortality rate in young children. It's just the opposite. And we don't really know why. This is what the virus looks like. You can see the COVID has got this spike protein or S protein on the outside, and that's what allows it to bind to the ACE2, the angiotensin converting enzyme 2 receptor, mainly on the epithelial cell wall in the upper airways. That's how this virus gains entry into the cell. And once it gains entry into the cell, it releases its viral RNA, and that viral RNA takes over the host cell and programs the host cell to manufacture more viral RNA to reproduce the virus, and then releases new viral particles from the host cell. That's how this virus lives and survives. And it mainly does it on, we believe, human cells that line the upper airways and even the lower airways into the lungs. And it sets up that inflammatory process we'll come back to that may cause a pneumonitis, a severe pneumonia and inflammatory process in the lung that leads to a lot of people having bad outcomes. And it may also cause direct toxicity to the myocardium as well. We're seeing that now with some new recent case reports. This is where we have a controversy that I don't believe is a big deal right now. It's nothing I'm going to do differently based on it, but this was a letter to the editor in Lancet Respiratory Medicine on March the 11th of this year. And basically this is hypothesis generated. And they are saying that human pathogenic coronaviruses like SARS-CoV and SARS-CoV-2, which is COVID-19, bind to target cells through that enzyme, angiotensin II converting enzyme 2, which is expressed by the epithelial cells that line the lung, the intestine, kidney, and blood vessels. We're mainly talking about the airways. And it's ACE2 is increased in patients with type 1 or type 2 diabetes, especially if they're treated with ACE inhibitors or angiotensin receptor blockers, ARBs. Those upregulate the expression of ACE2. And theoretically, that might enhance the ability of the coronavirus to enter the host cell. Theoretically, there is no evidence to support this right now. Hypertension, another risk factor. Many of our patients with high blood pressure are treated with ACE inhibitors or angiotensin II receptor blockers, ARBs, which upregulate ACE2 expression. Theoretically, the same thing. So that is their hypothesis. And they also go on to say they've seen the same thing with TZDs, the pioglitazone, rosiglitazone diabetes drugs, and with ibuprofen. Ibuprofen, Advil or Aleve, Motrin, may also increase the expression of ACE2. But they say, we hypothesize diabetes and hypertension treatment with ACE stimulating drugs increase the risk of developing severe and fatal COVID-19. That was hypothesis. And then several things have happened since. So the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America have published a recommendation March the 17th. So 1 week after this letter was published in Lancet, we see this response from these three organizations together, suggesting that we are not recommending you stop your ACE or ARB if it's for hypertension, it's for diabetes, it's for kidney disease, it's for heart failure. These are renal protective, they're heart protective, they reduce risk of mortality, reduce risk of MI and stroke. And if you stop them, you might increase your risk of cardiovascular events, renal disease, or bad outcomes. So right now, they are recommending we not do anything in patients treated with these drugs. We should continue them. And they do say that we are working as hard and fast as we can to look at any data that would suggest we need to do something differently. But right now, let's not panic. Let's not stop these meds, because stopping them may be associated with worse outcomes than the COVID-19 virus. So let's take a breath and wait for the data. And we've had lots of publications from different researchers, and right now we have no evidence to support this is something we need to be worried about. And our national guidelines say, don't stop your ACE or your ARB. Same thing with ibuprofen. This is even more interesting because the day this came out, the French health minister posted on his social media, his Twitter account, that we should probably not use ibuprofen or cortisone in patients with COVID-19. We should use acetaminophen because of this potential risk. And the World Organization on the same day said, yes, that makes sense. The next day, the World Health Organization came back and published this slide, comes directly from WHO, and it was on March the 18th of 2020. At present, based on currently available information, WHO does not recommend against the use of ibuprofen. We are consulting with physicians treating COVID-19 patients and are not aware of any reports of any negative effects of ibuprofen beyond the usual known side effects to limit its use in certain populations. That's mainly GI bleeding or somebody with aspirin sensitivity, asthma, those types of things. So they're not aware of any published clinical or population data on this topic. So right now, yes, you can use acetaminophen. It shouldn't matter to treat your fever. This is hypothesis generating from a theoretical standpoint based on one letter to the editor with no evidence. The other thing that is rapidly changing is testing. That's been a real problem with this disease worldwide. Originally in the United States, the CDC was the only place you could get testing, and CDC was making testing available, and originally the test was not very reliable. They had to redo it. It's still in very short supply. It took days to a week to turn around. You had to send it to a central lab. They had limited supplies. They ran out of reagents. It was a disaster initially. And the best way to prevent this is to know where it is. So you can practice social distancing if you identify a case, but you couldn't identify it. And most of us only had 1 or 2 labs in the entire state you had to send all your specimens to. Well, that is now beginning to change. This was the first point-of-care test, was approved by an emergency use authorization by the FDA on March the 21st by FAPha's Expert Express SARS-CoV-2 test, a point-of-care test that takes about 45 minutes from the time you start the reagents until you get the test results. And so it's beginning to be used. They were shipping it as of the end of March. It's starting to be used in hospitals, so you don't have to send it to a centralized laboratory. So this was the first one, okay? That was the FAPha's Expert Express. Oh, back up one. March the 18th, the FDA approved, again, emergency use authorization for Abbott's M2000 real-time system. And this is a PCR technology that is to detect the messenger RNA and the N nucleocapsid gene of the SARS-CoV virus. And this test can run about 470 tests every 24 hours, and this machine is available in over 175 hospitals in the United States. So this one you don't have sent to a central lab. Many hospitals have it, and they are producing, by the end of March, 1 million test kits per week. So we're seeing this one start to come up, and again, it's a PCR that identifies the COVID-19 virus, the virus particle. Both the messenger RNA and the N gene are both tested for with this test. So that's the second one. And the third one was just approved the end of March, March the 31st. This is the first 5-minute point of care test, again by Abbott. It's called the Abbott ID Now COVID-19 assay. Also got emergency use authorization by the FDA. It looks at the RNA gene of the coronavirus. It takes 5 minutes for a positive test, and it takes about 13 minutes if the test is negative to verify it's a negative test. They're producing about 50,000 tests per day right now, shipping them throughout the United States. And this one is a desktop portable unit. So this one is also now available by Abbott Pharmaceuticals. So we have 3 new, more rapid tests that should be available in your hospitals. And some people, you can get this one even for your office if you were doing office-based testing. But the other one is still the central lab that's usually by the state health department and the CDC. So these are hopefully going to increase our numbers to be tested which will also increase our numbers for our denominator when we look at our denominator data, which hopefully will bring down the fatal number of fatal cases as far as the percentage, because we're not testing nearly everybody that we believe has COVID-19. We also have another new test that was approved April the 1st, and this one is not used to make the diagnosis. This one is used to say that you've been exposed to the virus and your immune system has started to respond. This is the first serology test. All the others were tests on, you do a swab in the nasal pharynx for all the others. This one is a serology test. It can be done on plasma, whole blood, whatever. And it looks for IgM and IgG against the coronavirus type 2. So the IgM antibodies are detectable several days after the initial infection, and IgG are a little bit delayed in following them. And I'll show you what the curves look like here. This is again from the manufacturer, from the package insert for this new device, and this is what the device looks like. And you can see this is a control is positive, but so it's a negative test. There's no IgG and no IgM. This is if both are positive. This is just IgG positive, and this is if IgM is just positive. What you see here, the blue, is the RNA antigen. So this is the antigen. The IgM, you can see, becomes detectable about 6 to 7 days in, about the same time they have onset of symptoms, and then it goes back down. After about 21 days, it's back, it disappears. And this is what happens to the IgG. It doesn't start up till about 2 weeks. That's the red line, and it's here even longer. But it's also declining over time. And here's how they suggest you interpret the results here at the bottom. So you can look at it, but this may be most useful if we're looking for people to see if they've developed antibodies against COVID-19, and these are the folks that you might want to get to donate their plasma for the passive immunity that we'll talk about in just a minute. So this would be a test to show their immune system is responding to the virus and developing antibodies. So that's new. This is the infamous flatten the curves slide from the CDC. This was actually published by the CDC back in 2006. They did a hypothetical, what would we do if we had an influenza pandemic? And this is where this came from. So what it shows you is, what we're trying to do is delay the outbreak peak. So if we don't do anything with social distancing, we get this kind of response, this bright purple. And if there was a line in here, the line would go across here showing this is where our hospitals become overwhelmed, and it overwhelms the system. So if we can depress this curve, flatten it out, and move it this way, we can maintain a peak that is below the capacity of our healthcare system to function. So that's what we've been trying to do with flatten the curve. We want to flatten it so that we can survive this without overwhelming the system. I'm going to show you what this means with this next slide. This is data that just came out this week. This was April the 7th, yesterday, early yesterday morning, by our friends in the state of Washington. This is the same slide you saw the president's news conference, if you saw his news conference 2 days ago. And what it shows you is these are hospital resources used. And what you can see here, they expect April the 15th will be the peak for hospital resource use in the entire United States. Each state's a little different, but you put them all together, April the 15th is when we expect to reach the peak. And this would be the peak here, this purple, as far as hospitalizations. And if we flatten the curve, we can move it down to here. And what this is a median. This would be if we didn't use social distancing. This would be if we were most effective, somewhere in here. So this is the median. And they also look at here in green, the number of ICU beds that would be needed. Over 29,000 is the peak. And the number of ventilators that we needed in blue. So these are down here. And these are, you can see, ICU beds. We're exceeding the number of ICU beds. We're exceeding the number of all beds in hospitals if the peak were to go here. By bringing it down here, we're flattening the curve some, and we're allowing the system to respond better. And there's a curve for each state in this data set. So each state has one, and states like New York and New York City in particular, they're exceeding the capacity of the healthcare system in hospital beds, as also in ICU beds and with ventilators. And that's the good news, is that the military has come in and set up additional hospital beds. We've sent ventilators from California to New York City, where California has not needed all they thought they were going to need. So we're redistributing the available supplies that we have, including protective equipment. So all these are things that we can share based on what these projections are. If our projections in our state are where we have excess capacity, hopefully we can share some of those supplies with states that are being harder hit than the rest of us. So this is where this slide comes from, and we hope that these numbers are going to be down here, not here. This is a median. We hope we're going to be somewhere down here. And as of the last day or so, it looks like we may be flattening the curve a little better than that median, so we may be underneath it somewhat. But stay tuned. We don't know yet. Here is where the CDC, again, this was in 2006, they published this. So this is before the current outbreak. And what it shows you is case fatality rate percentages over here. Category 1 has a case fatality rate less than 0.1%. That's usually where we are with seasonal flu. And if we have that case fatality rate of less than 0.1%, the total number of projected deaths would be about 90,000 deaths if we're down that low. As this projected fatality rate goes up, these numbers go up dramatically, and you shift this graph from yellow to orange to red to purple to black. So right now, nationally, the World Health Organization says we're somewhere closer to 3% is our case fatality rate worldwide. And again, it's probably significantly lower than that because we don't have good denominator data. We don't have enough testing available to tell how many people have had the disease. Okay, so we don't have the numbers we'd like to have. But you'll note, we are at least in this purple category, and if we were in the red to purple, every one of these interventions is what's been recommended for us to do. We've never done it before. We've always been in the yellow. The only thing recommended was voluntary isolation in people who had antiviral treatment and those who have symptoms. Now we're recommending pretty much every one of these. We've voluntary closure of work and school, social isolation, keep 6 feet apart. All those things have been put in place, and these were recommended by the CDC in this report in 2006. So this is not something we've just come up with. It's been in the pipeline, but we didn't do a very good job preparing for it. We didn't have the stockpile of the protective equipment we need, the ventilators. We didn't have a plan in place. Now we're trying to come up with it all of a sudden. We've done pretty well, but not where we'd like to be. So what can we do about it? Vaccine we'll come back to in a minute. One of the things that's been done in New York City was done in China, and I'll give you a little bit of data, is can we make a convalescent serum? Can we take people who've already been cured of the COVID-19, their immune system has responded, they have natural antibodies against COVID-19, take their plasma, and then give that to other people. So pooled plasma from people who have recovered from COVID-19 infection. So our friends at Takeda have a plan in place to do this right now, at a plant in Atlanta, Georgia. So this is currently under investigation by Takeda to do that, and they believe it should be available in 9 to 18 months, but it's already happening. Here was the first report in JAMA, March the 27th of this year. This comes out of China. It's 5 critically ill patients with laboratory confirmed COVID-19, met the following criteria. They had severe pneumonia, rapid progression of high viral load despite antiviral treatment. They're from one hospital in China over a period of about 2.5 months, and patients were given convalescent plasma with SARS-CoV-2 specific antibody, IgG, binding titer greater than 1 to 1,000. And 5 patients were given this plasma, and what happened, most of these 5 recovered within 10 and 22 days after admission. That was published in JAMA, and you can see the age range was 36 to 65, 2 women, all on mechanical ventilation at the time, all receiving antiviral agents and methylprednisolone. Body temperature normalized within 3 days in 4 of the 5 patients. SOFA score decreased, viral loads decreased, became negative within 12 days, and ARDS resolved in 4 patients in 12 days. 3 patients weaned off mechanical ventilation within 2 weeks of treatment. Of the 5, 3 have been discharged, but look at the lengths of stay. 50 days. 2 are stable condition at 37 days after transfusion, but still in the hospital. This was the first 5 patients. This was just presented even more recently. This was available online as of 2 days ago from the proceedings of the National Academy of Sciences. 10 patients, again from China. They were all positive for COVID in Wuhan, 3 different hospitals in Wuhan province. They're different than the first set. They got 200 cc's of convalescent plasma derived from recovered donors with neutralizing antibody titers above 1 to 640. They were transfused. What they looked at was what happened to their oxyhemoglobin, increased within 3 days. Their lymphocyte count increased. Their C-reactive protein decreased. Viral load was undetectable after transfusion in 7 patients who had previous viremia. No severe adverse effects. So again, it looks promising that convalescent serum, this has been around for decades. We've done this for other diseases. So this is probably the most available thing to us to do, to use convalescent serum from patients who've recovered successfully from having the disease, and we administer it. So this is passive immunity, not active immunity. Vaccine development, which would be ideal, but it's going to take time. The first vaccine has already gone into clinical testing. So it went into clinical testing back in March. We saw the first doses given by Moderna. Cambridge, Massachusetts is the group that had the first one. It's a messenger RNA that serves as template for making the protein of the virus. And it's been directed to produce the spike protein, the S protein. And early clinical trials are underway for safety right now. Small numbers, I'll show you the data right now. 45 healthy patients at 3 months. It's to begin in the spring. It has begun. Primary aim, dose ranging trial to evaluate safety and reactogenicity of a 2-dose schedule given 28 days apart. So this vaccine is already under testing, and if it shows that it's safe and it looks like it shows benefit, then move into a combined stage 2 and 3 testing that may take at least 12 months to get the results. So at best, we're looking at probably a year to a year and a half from now before we can hope to have a vaccine. And this is the only one that's in testing. We have several others. There are about 15 or 20 different vaccines in development. This is the only one that is currently already started phase 1 testing. This guy is a real American hero. Dr. Anthony Fauci. Dr. Fauci is director of the National Institute of Allergy and Infectious Diseases. He's 79, soon to be 80 years old. And he's the one who is driving a lot of what we are doing. And he says there's a lot of empiric guessing. They're going to propose a whole lot of drugs that already exist. They're going to say, Here's the data that shows it blocks the virus in the test tube. But test tubes aren't people, and many drugs seem to work in a lab, won't end up helping patients. This is where he's had to kind of, if you see him behind President Trump, when President Trump touts hydroxychloroquine or some of these drugs that look like that might be beneficial, go ahead and try them. He's trying to put some perspective on it. We don't have controlled trials yet, guys. We really need to know what these drugs do and don't do. Well, we're going to find out because we got a lot of trials underway. But I think Fauci is got to be the scientist in the group. And he also tells us we don't have an animal model to look at when it comes to the coronavirus. So we're still looking at, is there a good animal model we can use for this virus? And he said here, and this is a quote to CNN, let me put it in perspective for the viewers. There have been anecdotal, non-proven data that chloroquine or hydroxychloroquine works. When you have an uncontrolled trial, you can never definitely say that it works. That's a quote from Dr. Fauci. So let's look at the data and let's look at what we've got coming. So here's a study out of Norwegian University of Science and Technology that came out in February of this year that looks at, again, in vitro, what are the drugs that look like they're going to work against this specific coronavirus. Remdesivir we'll talk about, chloroquine, lopinavir, ritonavir we'll talk about, and we'll also talk about several other drugs. For example, be azithromycin, Zithromax. So let me show you what we do know. The next slide is the study that got, I think, Gilead's stock went back up again, even though we're in the decline right now. Gilead's the manufacturer of remdesivir, and it is a nucleotide prodrug, was actually studied during the Ebola outbreak, was studied during SARS and MERS. And what we found is that it does appear to have good data against this virus, and it's actually being studied in a controlled trial at University of Nebraska Medical Center in Omaha. It was actually started last month, and there are 2 different IV doses. It's an IV drug. They didn't show any significant adverse events when it was administered to the first person who was given the drug in a compassionate use, 35-year-old male with atypical pneumonia, had recently returned from China to Washington State, and he got the drug at University of Washington and was recovered. We don't have a lot of data yet, but was one case. And basically, the folks at the Chinese Academy of Medical Sciences, where they have approved the drug, say it's highly effective in control of 2019 nCoV infection in vitro. And they reported this in February the 4th in Cell Research. So let me show you what's going on with this drug. So back up. The first study is 400 patients with severe clinical manifestations of COVID-19 receive either 5 or 10 days of IV remdesivir. 400 participants 1-to-1 to receive 200 milligram on day 1, followed by 100 milligram each day until day 5 or day 10, in addition to standard of care. Primary objective is evaluate the effect of the drug as measured on normalization of fever, oxygen saturation, and they're going to look at clinical outcome through day 14. So that's study number 1, using the 2 doses IV for 5 or 10 days. And the second study, 600 patients with moderate clinical manifestations, 1-to-1-to-1, 200 milligram day 1, followed by 100 for each day for 5 or 10 days. And the primary objective is to evaluate measured on discharge by day 14. So this one is also currently underway. And Gilead is sponsoring both of these. There's also data out of China, where Gilead has 2 ongoing clinical trials with the Chinese-Japanese Friendship Hospital, and again, Hubei province. One study of patients with confirmed disease who have more severe clinical manifestations that require supplemental oxygen. The other who have been hospitalized but are not displaying significant clinical manifestations such as oxygen requirement. Both of these are underway, and Gilead says we anticipate some results this month. So stay tuned. We ought to have some original limited data from these two ongoing trials in China later this month. Gilead also announced earlier in the month compassionate use, but they took that away as of March the 22nd because they were overwhelmed. They had way too many requests, so they are still doing a few, but they're no longer receiving requests for compassionate use, even though the FDA would allow them to do that because they don't have enough material available, and they need to make sure they supply all the ongoing clinical trials with the drug right now. So Gilead's trying to ramp up the production of the drug, and compassionate use is currently on hold as far as new requests for compassionate use. So stay tuned. The World Health Organization back in February said this was the most promising drug that they were aware of in the pipeline that would be potentially available to treat patients before the end of the year. So stay tuned on this one. Remdesivir by Gilead is number one on the hit parade right now. Oop. Come back here. My mouse and I are not getting along today. This is the data on the HIV combination, lopinavir, ritonavir. These are two protease inhibitors for HIV. Ritonavir inhibits the metabolism of lopinavir and raises the levels substantially. So this was a report in New England Journal, March the 18th, of 199 adults hospitalized with COVID-19 from Wuhan, China. And the results suggested no benefit in terms of time to clinical improvement in patients who received the drug combo versus placebo. So this one I'd put on the back burner. So while we had some hopes for it, did not appear to pan out based on the first data. This is the one that got our president excited and got lots of us excited. And this again is a preliminary non-controlled trial from a hospital in Marseille, France. It's only a small number of patients. It's not a controlled trial with hydroxychloroquine, and some of these people also got azithromycin zithromax. All these patients were hospitalized with documented COVID-19. There was positive on nasopharyngeal sample at admission. 16.7% were asymptomatic. Another 61% had basically upper respiratory tract infection with low-grade fever and myalgia, and 22% had lower respiratory tract infections with pneumonia bronchitis. So the severe cases were only 22%. All patients were given oral hydroxychloroquine 200 milligrams 3 times a day for 10 days, and if they refused treatment, they were put in a control group. It is not a placebo-controlled randomized controlled trial. The primary endpoint was virologic clearance at day 6 post-inclusion. Among the hydroxychloroquine-treated patients, 6 received azithromycin zithromax, 500 milligrams on day 1, followed by 250 a day for the next 4 days to prevent bacterial superinfection. The other thing that azithromycin does, it's anti-inflammatory. We use it in COPD. So that may be another reason that it might show some benefit, but it was used in this study because they were worried about bacterial superinfection. Here's the graph that got everybody excited. What you see, the black line, 14 of the 16 patients, these are not treated with hydroxychloroquine or azithromycin, were still had positive PCR samples, 87.5% at day 6. If they got hydroxychloroquine by itself, 6 of the 14, or 43%, were positive at day 6. If they got hydroxychloroquine plus azithromycin, none of them were positive at day 6. The problem is this trial didn't give us any clinical data. We don't know what happened for these 6 patients. That's still to come. Okay, they said this is an interim report, based on what we've seen so far. This is what got people excited. Well, we now have some more data. This was actually published again online, March the 28th. This is a follow-up of 80 patients with COVID-19 hospitalized at a different center, not the same one that used the combination. And all patients here got hydroxychloroquine azithromycin for at least 3 days. And they were followed up for at least 6 days to be included in the analysis. 57.5% had at least one chronic condition known to increase the risk of bad outcomes. So hypertension, diabetes, respiratory disease. The time between onset of symptoms, hospitalization on average was 5 days. The longest being 17 days. 54% had lower respiratory tract symptoms and 41% had upper respiratory. Only 15% were febrile. The mean time from onset of symptoms to initiation of treatment was right at 5 days. Most patients were treated on the day of admission or the day after. They got the 2-drug regimen. Okay? Clinical course. 65 of the 80 patients excuse me, had a favorable outcome and were discharged at the time of writing. So 65 of these people were actually discharged from the hospital. Contagiousness is assessed by repeat PCR and culture. Rapid fall in nasopharyngeal viral load by PCR was noted. 83% of patients negative at day 7, 93% negative at day 8 after this therapy. Length of stay in the ID ward. Of the 65 discharged patients, the mean time from initiation to discharge was 4.1 days, with a mean length of stay of 4.6 days. So if this is true, this is great results. So stay tuned, we got lots more going on, but this again is a non-controlled trial. Observational data, not a controlled clinical trial. So trials underway. University of Minnesota has a 1,500 patient trial began back in March to see if you could treat it with hydroxychloroquine to prevent or reduce the severity of COVID-19. And they have 2 trials with losartan and ARB because to measure whether the hypertension drug reduces the risk of organ failure in COVID-19 who have been hospitalized. So this is actually seeing if losartan could be beneficial, not harmful. And if it's going to be harmful, they should know in this study as well. So this is also just getting underway at University of Minnesota. This is a fascinating slide that also was alluded to by our president in one of his press conferences. What it shows you is COVID-19, the yellow countries, and in the blue countries are where malaria is. And what you'll note, where malaria is, COVID-19 is not. And this was put together by a meteorologist. This is not somebody who's in medicine. This was published on Breitbart, a political piece, and our president referred to this, that countries that have malaria that use these antimalarials don't have COVID-19. So cause and effects not established. This again is hypothesis generating at best, but this is where it comes from. This is the slide that our president took his information from. It's also being studied for post-exposure prophylaxis. So this is being studied at New York Presbyterian, Columbia University, Irving Medical Center, New York City, 1,600 adult contacts with COVID-19 patients. So underway, 2 400 milligram hydroxychloroquine twice a day on day 1 for 2 to 5 days. So now 1 tablet twice a day. This is the FDA's emergency use authorization for hydroxychloroquine and chloroquine. On March the 29th, the FDA said we will allow physicians to use, even including the drugs from the strategic stockpile, to treat patients with COVID-19. Sandoz had donated 30 million doses of hydroxychloroquine. Bayer donated 1 million doses of chloroquine. And as of yesterday, India has lifted its embargo to the Indian drug companies, they can ship hydroxychloroquine to the United States again, since 50% of our world supply for hydroxychloroquine comes from India. India had shut it down. They've opened it up again yesterday at President Trump's request. So Novartis chief executive officer told a Swiss newspaper, hydroxychloroquine is our biggest hope on combating COVID-19. But he's the chief executive officer for Novartis, who owns Sandoz, who is the largest U.S. producer or marketer of hydroxychloroquine. So could be a little bias here. Couple of cautions with animal areas. Chloroquine we don't use as much as hydroxychloroquine for good reason. Chloroquine's not as well tolerated, and if you take chloroquine, you need to be tested for G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency. It's the second most common human enzyme defect, affects about 400 million people worldwide, 1 in 10 African American males. It's Africa and around the Mediterranean Sea is where most of it is. If you take chloroquine and have G6PD deficiency, it leads to hemolytic anemia, jaundice, shortness of breath, and tachycardia, and you can have acute kidney failure and die from it. So it's a contraindication. Hydroxychloroquine, on the other hand, good news, does not have the same problem with G6PD deficiency. So chloroquine is unique in that regard. Both drugs, however, cause QT interval prolongation. QT prolongation is a potential problem with both hydroxychloroquine and chloroquine. And we use these drugs routinely to treat people with discoid lupus, rheumatoid arthritis, and malaria. We've used them for decades. But you have to watch out for eye toxicity with long-term high-dose use, but that typically doesn't occur until you've been on drug for 5 years. So that shouldn't be a problem with this drug for this indication. But QT prolongation could be a problem. And typically, if your baseline QTC, corrected QT interval, is greater than 450 milliseconds in males, 470 in females, that puts you in a higher risk, and we need to do some more monitoring. So here's a slide that comes from our friends at the from the Arizona CERT. And what it looks like is if you're got somebody you're concerned about, make sure their serum potassium is above 4. Make sure their serum magnesium above 2, because that will reduce their risk. Stop any other unnecessary drugs that cause QT prolongation. And there's a website here at the bottom, the link from Mayo, and also you can go to the Arizona CERT and check out what drugs do what. The major reason I'm concerned here is if you use azithromycin, the macrolide, Zithromax, it also causes QT prolongation, and it's additive to hydroxychloroquine or chloroquine. So you have to monitor these folks if you're going to do this, especially if they're high risk. So that's where this comes from. The last drug issue that is unique, and again, who would have thought, is IL-6 receptor blockade with monoclonal antibodies. And we have 3 of these guys on the market today, but we have one that has some preliminary data from China. Tocilizumab, Actemra, has been used in the COVID-19 patients with severe respiratory distress, especially with pneumonia and pneumonitis, inflammatory, to manage the cytokine release syndrome, CRS, and that's what this drug was approved for, to manage cytokine release syndrome in patients who get CAR T-cell therapy. So they thought, why not try it in people with COVID-19 who have severe pneumonitis? So investigators, Italy and China, have used it to treat it at comparable to those used for CRS, and reported rapid improvement in both intubated and non-intubated patients. So again, this is non-controlled, anecdotal data, hypothesis generated. So this was 300 patients to recruit worldwide, and they got all 300 patients in less than 24 hours. This study was fully enrolled in less than 1 day. It's underway. Genentech will provide 10,000 vials to the strategic stockpile, and was approved in March by the Chinese government to treat patients with severe lung damage in China. It was already given an indication for COVID-19 in China. The other two, other than Actemra, are also seen on this slide, and they're also being studied. But right now, we don't know, but this is an option. So this is one of the things that we might consider for severe patients who have severe pneumonitis, that cytokine release syndrome. Could be our immune system is over-responding to this virus, and that could cause not only the pulmonary toxicity, theoretically could cause the cardiotoxicity as well. So stay tuned. This is another very hot topic that is getting a lot of attention right now that shows some promise for patients with COVID-19.